now it's my pleasure to introduce our next speaker, Dr. Claire Spahn. Claire Spahn is a clinical pharmacist in neurology at Stanford Neuroscience Health Center, excuse me, in Stanford, California. In this role, she works collaboratively with providers at various neurology and neurosurgery clinics, where she manages patients' medications, including managing side effects, dose adjustments, and lab monitoring. Additionally, she staffs at the Outpatient Infusion Center, supervising sterile compounding and providing medication counseling and medication reconciliation services to patients. Claire has worked on several investigational drug protocols for clinical trials in neurology. She also precepts pharmacy residents, creates patient education materials, and presents CEs and lectures annually. Claire graduated with her PharmD from Western University of Health Sciences in Los Angeles, and she completed a PGY1 acute care pharmacy residency at Stanford Healthcare in Stanford, California. She is credentialed by the Board of Pharmaceutical Specialties as a board-certified pharmacopathy specialist. Thank you so much for being here today, and I will turn the time over to you.
Thank you so much, Sarah. And thank you so much to Dr. Mipiti, who's my one of the wonderful neurologists that I work with at Stanford in California. And I'm really pleased to be a part of the forum today. It's one of the upsides of a global pandemic that we have these webinar opportunities to get together, and it's lovely to see the interest from the MG community and see so many patients and caregivers on the call. And I always appreciate learning so much from patients and caregivers, so thank you. So as Dr. Mipiti has already mentioned, and thank you to Sarah for that introduction, we work at Stanford Neuroscience in California. This is a building. And for the patients with neurology, this is the Stanford Neuroscience Health Center. We cater to something like 20-something different neurology subspecialties, including neuromuscular diseases like Myasthenia Gravis. And we're very fortunate in this building. We have very much a one-stop shop. We offer all kinds of amenities from radiology to procedure rooms, infusion center, and research in the same building. So that's enough about me. Moving on to my agenda today, I'll talk about just some simple medication management tips that are applicable to any medication. I know that sometimes people are diagnosed later in life and might not be used to taking any medications. So we'll just do some quick tips and then dive specifically into medications that are utilized for myasthenia gravis, namely the goals of therapy, the different medications we typically use, how we decide which treatment we would use for which patient, how you can best manage exacerbations and side effects, and indeed some drugs you should avoid if you are diagnosed with myasthenia gravis, and then some resources. So just some general medication management tips at the outset. And here we have a picture of a prescription label. And I know very many of you are very familiar with this, but I do just want to draw your attention to a few items here. I've drawn some red boxes around because these are things that do occasionally come up in clinic. So you'll see here in this section, we have the date that the prescription is filled. Now, I really encourage people to please keep your prescription medications in their original bottles until you go to fill your weekly pill box. I'm a big advocate of the weekly pill box, but otherwise they should be in the original bottles. I do see occasionally issues where patients combine multiple bottles into one bottle. So we have sequential months, and then we're not sure what the actual expiry date of the medication is. And we definitely don't want patients using medications that are beyond expiry date. Another area of the prescription I want to draw attention to is the quantity or number of pills in the bottle and the number of refills remaining. If there's refills remaining, your pharmacy can go ahead and refill that for you. You don't need to contact the doctor's office for a new prescription. And I know these things come up and people get in a panic occasionally when they think they don't have refills yet left. So that's why it's always a good idea to keep your meds in their dispensed bottle, and you can check what refills you have remaining. And then finally here, always check what is in the bottle and make sure it matches the description on the label. There's humans involved in the dispensing process, and there's always, they take great care to make sure that everything is done correctly, but there's always a very small chance for error. So make sure that you satisfy yourself that what's in the bottle is exactly what is being described and that you have the correct prescription. For example, sometimes pharmacies move between different manufacturers of drugs. So it might well be that the drug looks different, but that it is the correct drug. And this is a way that you can double check. If ever in doubt, always stop and ask. So ask your pharmacist if this is the correct medication. Make sure you satisfy yourself that there is no error involved. Okay, so some additional things I want to mention in addition to the prescription labels are also storage. So ideally, medications should be stored in a safe place out of reach of children and pets. Typically, we recommend not storing in the bathroom. I know we all tend to do that, but that is a source of humidity and heat, which is not great for medication stability and potency. So if you can, make sure you try and store somewhere that's safe, but in a not humid place. Brand versus generic. These are generic manufacturers and tablets and medications are FDA approved and are equivalent to the brand name drugs that you might be more used to. So you should absolutely have the same efficacy. They are safe and meet the same standards per FDA. So totally safe to switch between brand and generic manufactured drugs. The only difference that may happen is that there would be some different other ingredients that are in there. As you can imagine, medications are perishable and there's ingredients like stabilizers and preservatives and different things like that. So it may well be that patients are more sensitive to one than the other. But in terms of therapeutic efficacy and safety, they are absolutely the same. And finally, disposal. There's a general recommendation from FDA that we don't rush to flush, meaning that we should not introduce our leftover or unused medications into the water supply for safety and environmental protection. FDA does allow for flushing of controlled medications, but in general, there's a recommendation to render the medication unusable. If you're disposing at home, you can mix with some coffee grounds or some other waste and dispose of it in the trash, or you can check with your local county disposal or indeed check with your dispensing pharmacy for our drug take back programs and for their recommendations where you can bring extra medications to be disposed. Now, just regarding taking your medication, some items to address here are first timing. Very often when we write prescriptions or when we order medications for patients, we tell them to take them twice a day. And we never think to take that extra step to say, really by twice a day, what we actually mean is once every 12 hours. And I often pick up on that when I'm talking to patients and ask, tell me how you take those medications and what time of day you take them. And the reason for something that would be taken twice a day, having that in an every 12-hour schedule is really to try and keep a consistent level in your body throughout the 24-hour period so that you're not having times of higher drug levels that may lead to increased side effects or lower drug levels that may leave you at risk for not really achieving the full efficacy or benefit of taking the drug. Secondly, here is food. So some drugs are ideally taken with food. For example, we'll often recommend that you take your prednisone in the morning with breakfast, both because it's irritant to the stomach and also because it can disturb sleep. So we recommend that it's taken earlier versus later in the day. And analogous to that, other medications work better on an empty stomach. So mycophenolate or Cellcept will achieve a much greater level in the body if you take it on an empty stomach. That said, some people tell me that they find it quite nauseating to do this. So we recommend in that case, it would be a small snack, like a few crackers, is not going to really effectively decrease the drug level so much as a big heavy meal. Alcohol is generally recommended only in moderation. So we want to take care, not only be aware of side effects that might happen by mixing alcohol with the drugs or any contraindication to drinking with medications, but also just additive side effects. If you're taking any medications or your disease state is causing you to be weaker or maybe less coordinated, adding alcohol on top might not be a great idea. So that's going to be a patient-specific thing, but definitely always in moderation and minimal as possible. Medication duration. So some of the medications that we use for myasthenia gravis, we recommend that patients are taking longer term versus other medications, things like prednisone that can have associated side effects. We're going to be trying to wean those off to avoid longer term side effects. Missed doses. So generally as pharmacists, we recommend the halfway rule, meaning that if you realize you've missed a dose and it's less than halfway to the next dose, then you should go ahead and take that medication once you remember it. So for example, if you usually take your CellCept at 9 a.m. and 9 p.m. and you realize at noon that you've missed your dose, then go ahead and take that dose at noon and continue your usual dosing regimen at 9 p.m. that night. If it's more than halfway beyond the dosing window, so more than 6 hours late in this case, if it was 5 p.m. that you remember, just skip the dose and continue with your dosing regimen at 9 p.m. as usual. Please don't be tempted to double up on doses to make up for the missed dose. We don't want you at risk of having too high a level in your system and leading to side effects. And then what to expect with medications. This is something important that you should ask at the outset if it's not being offered or explained to you. I'll give you an example of a commonly used medication like a beta blocker that patients are oftentimes given for hypertension, for high blood pressure, or for other cardiac indications. Oftentimes when you're started on a medication like that, you feel a lot worse before you start to feel better. But if you didn't know that up front or know to expect that, you might be disappointed or might be tempted to not continue with that medication. So make sure that you're understanding everything, understanding side effects and what you should expect up front before you're starting on a new medication. So briefly, some quick tips to remember medications. One thing I often recommend to patients is alarms. And nowadays we all carry smartphones, so it's a great idea to use that to set some alarms for yourself. Oftentimes we ignore alarms, so maybe set two, set one and have a second alarm 15 minutes later as a reminder in case you were tempted to turn off that first one and forgot to take action. Weekly pill boxes are a great idea. When you're used to taking something every day or multiple times a day, sometimes it's hard to remember, did you actually take it as you had intended to do? And having that nice visual check of your pill box, oh, it's empty. Okay, I must have taken that this morning, is a nice way of keeping on track of taking your medications. Timing your medications around your daily activities can be very helpful, particularly if you're somebody who's very strongly routine driven, like you always get up at a particular time and make breakfast, maybe keeping those medications in the kitchen nearby where you go to make breakfast. And similarly, if you have something in the evening time that you can identify as a reminder to take your medications, that's always very helpful. There's many medication reminder apps nowadays. You can just go to your preferred search engine and type in medication reminder app, and there's several that will populate for you with different features, and you can figure out which one will work best for you. And finally, always good to enlist some help from a family member or roommate or whoever lives with you or visits you on a frequent basis, either to help with your weekly pill box or just checking in about how your medications are going. So moving on specifically towards myasthenia gravis, I know that Dr. Mipidi already went through a lot of the pathophysiology and a lot of what I'm going to speak about, but I'll just revisit quickly in case there's some new additions to this call that missed maybe the earlier talk. So myasthenia, as you well know, is an autoimmune disease, meaning that the body is making problematic antibodies that are attacking its own self. It's characterized by skeletal muscle weakness, and really the core manifestation being that this is fatigable skeletal muscle weakness. So as you're using that muscle more throughout the day, it's getting weaker and more tired. However, taking a rest is almost like a reset button and the muscle becomes stronger again. So fatigable muscle weakness. And the cause are antibodies that are binding to the receptors on the muscle surface. So you'll see here in the diagram on the left, this is normal state. This yellow figure here is a neuron or a nerve. And this conducts a message from our brain all the way down the nerve fiber to the muscle. And the message is passed along by these little neurotransmitters. In this case, it's acetylcholine. And these are released and travel across this neuromuscular junction where they bind to receptors on the muscle membrane and tell the muscle to contract. Now, that's a little bit of a simplistic view, but that gives you enough of information of what's actually happening to understand where we're going with our drugs and our targets. On the right here, in the case of the myasthenia gravis scenario, again, we have the same neuron. Everything is the same here, same neurotransmitters released into the neuromuscular junction. And this diagram, I guess it's not super exaggerated to show, but there's fewer receptors here on the muscle effector, and there's blockade, meaning that the muscle cannot contract as effectively. So this muscle is getting tireder and weaker and not working as well as we might expect in the scenario here on the left side. Now, regarding symptom burden, I include this slide because it's interesting to me and an education point, I think, for both providers and patients alike. The data here comes from a study that was conducted by researchers in the US in 2022. And these researchers conducted one-on-one interviews with 28 people living with generalized myasthenia gravis, and they were looking at the impacts and the treatment goals of the patients. And something I found intriguing about this study was that there was these two columns that came out of it. There was patients, the symptoms that were most frequently reported by patients on the left side, which is what you would capture on your MG-ADL score that you complete at your doctor visit, versus on the right side, the symptoms that were actually most bothersome to the patients. And you'll see that they're not perfectly in alignment, meaning that what we are talking about at the visits or at the clinic visits or when we're checking in is not necessarily what is most problematic or what goals are for patients. So my takeaway from this study, it's really taught me to frame my approach differently to patients, not only asking what are the symptoms that are happening, because of course we have to address that, but also really trying to focus in on what is bothersome to you. And I encourage you folks as patients, caregivers, and family members to really keep this in mind as you prepare for your neurologist visits, or indeed any health visit that you may have, to really rank what the things are that bother you in your day-to-day life, because the provider doesn't necessarily know what it is that you like to do or how it is that your symptoms are disturbing or interfering with your daily activities. So really rank that and have your goal, your 1, 2, 3 items when you're going into your appointments, and make sure that you're addressing that and that you're working together as a team and how you can best achieve a positive outcome for your daily activities. We're all unique in what we enjoy doing every day, so we want to be able to tailor our care to what our patients need. Our treatment goals come to us from international consensus guidance for management of myasthenia gravis, and they are minimal manifestation status, meaning no symptoms and no functional limitations, maybe a little muscle weakness on exam, but really we're striving for a lot of improvement on symptoms. Of course, minimal side effects. It's not good to be taking medications for benefits if they're causing more harms or more side effects than they're really causing benefit for patients. And then thirdly is remission, so no signs or symptoms of myasthenia gravis. And to that end, we use different medications, various different classes, which Dr. Mipiti has already alluded to. But broadly speaking, we can bucket them or group them into 4 separate groups here. Firstly, being symptom control, which would be pyridostigmine. The second group is the rapid immunomodulating treatments, which include things like plasmapheresis or PLEX, also IVIG and the FcRn blockers, which I'll talk about shortly. Third group would be the chronic immunomodulatory treatments, and those would be things like the oral immunosuppressant drugs and also steroids or prednisone. And then lastly, surgical treatment or thymectomy. And indeed, not all patients will need or receive each type of therapy during their course of MG. These drugs can be used in combination, and we'll see some patients taking several medications, like the prescription on the right would be a fairly typical prescription. And some, thankfully, only are very well managed, maybe on just pyridostigmine alone. So it's very interpatient dependent. So how do we decide which treatment for which patient? So there's a number of factors that go into this decision. This is just one of 2 slides on this. Firstly, we would have to consider disease classification and disease activity. So Dr. Mipiti already reviewed antibody status, for example. Are you acetylcholine receptor positive? Are you seronegative? That's going to impact what drugs are applicable. How is the disease activity at present? Are you presenting fairly stable, newly diagnosed, but not too symptomatic? Or have you been admitted to the hospital from the ED because you're being so impacted by symptoms? Then we're going to be heading toward a lot more therapies or more aggressive treatments, obviously, to stabilize the patient up front. Second factor is cost and insurance coverage. So like every area of medicine and healthcare, the conversation goes beyond just what the patient and the prescriber recommend or agree as an ideal therapy. The insurance provider has to approve that therapy. Sometimes we'll notice that what is recommended or what is an ideal next step may not be okay with the insurance, and it has there's guidelines that maybe something has to be tried and tested before a patient can move on to another recommended therapy. Comorbidities are other disease states that are going on at the same time. So sometimes patients with immune conditions can have more than one condition going on at one time. So at a minimum, when we're making decisions about treatment, we want to make sure that our treatment for one disease condition is not going to adversely impact or exacerbate another illness that's going on at the same time. And ideally, your specialists would work together and formulate a plan whereby you could use one therapeutic regimen or cocktail or single drug to treat both conditions in a perfect world. Next consideration is drug availability. Thankfully, we have not encountered many shortages in recent years. I recall in past years having issues with IVIG availability in particular. And ideally, we don't like to switch between brands too frequently with that. But fortunately, that has been less of a consideration in recent years when we haven't really had drug shortages affecting medications for MG in particular. Next would be patient preference for site and route of administration. So while some patients might really prefer to have these infusions at home, especially if they take a long time or if mobility or access or transport is an issue, other patients really don't want these medications coming into their home life, and they prefer to go to an infusion center or prefer to avoid infusions entirely and go with another modality like an injectable drug or an oral drug. And then lastly on this slide is clinical trial criteria. So obviously it makes sense that if the drug has been studied and is well understood in a particular population and you fit those criteria, then you would be an ideal candidate or a better candidate for that drug, versus if there's some factor going on with you that was a mitigating factor or an exclusion criteria for a clinical trial, then maybe that's not an ideal drug for you. Other things we need to think about are side effects. Some patients have preference for avoidance of specific side effects, and what might be tolerable to me might be just not even not negotiable for somebody else. So that's unique to each patient and something we need to take into consideration. Next is adherence and safety monitoring and making sure that we're picking a regimen that is going to be possible for the patient to keep up with and to manage on a day-to-day basis. Family planning is of concern if we have a patient of childbearing potential and who's considering pregnancy either imminently or at some point in the future. And indeed, if they're planning to breastfeed, so that we have to think about which drugs might be suitable versus unsuitable and planning for that as well. And then vaccines or prophylaxis. So some of the drugs we're using, most of the drugs we're using are hitting the immune system. That is our goal, to just calm everything down and modulate the immune response. But by doing so, we are technically putting patients at risk for infections. So in some cases, there are required vaccines. And at a minimum, we want to make sure that everybody is up to date on their age-appropriate vaccines. And if needed, that they can take some antibiotics to protect from infection. So some medication management tips here for myasthenia. So firstly, for symptom control, I think many of you will be very familiar with Mestinon or pyridostigmine. And this drug really addresses the symptoms of myasthenia gravis, but really doesn't get at the underlying pathology. So it's great to help patients feel better from a day-to-day. This drug is available as syrup and tablets, and there's also an injection solution, and it helps just to increase the chemical messenger conduction from that neuron down to the muscle. It's very well tolerated. It acts pretty quickly within about 30 minutes, and you'll get benefit for 3 to 4 hours. So it can be taken several times over the course of the day. Now, I do list a column there with potential side effects. Now, not every patient experiences all or even any side effects, but these are some things that you may expect with this drug. And with the Mestinon, it's particularly at higher doses that patients will report some cramps and diarrhea, and even some muscle symptoms or increased saliva production. Secondly, here I have prednisone, which helps with symptoms, but also is really working on the immune system to decrease inflammation and suppressing the immune activity. The prednisone is very broadly acting and very effective. You'll see benefit within a couple of weeks here, but unfortunately, its use is limited by its side effect profile. Patients typically do not enjoy taking prednisone, and we're always working closely to try to decrease it as much as we can, but we have to be very patient with this one and decrease it slowly. The worst thing is to have to decrease it a number of steps and to then get impatient and try and go too fast and end up having to increase right back and start again. So we always have to be patient with this one, unfortunately. Some of the concerning side effects are the things that we can't see. So as you can imagine, increased blood glucose, cholesterol are generally not symptomatic. Blood pressure is usually not symptomatic. We don't know that we have high blood pressure unless we're going really high and getting headaches. We're at increased risk for infection. In long-term use, steroids can weaken bones. And there can be some neuropsychiatric side effects, meaning at a minimum, some mood irritability, changes in mood, just being a little impatient or irritable, maybe some sleep disturbance, vivid dreams, or difficulty falling asleep at night. And some patients who have some psychiatric conditions at baseline, like depression or other things, might find these really hard to take. These might really affect their mood too much. So the commonly used oral immunosuppressants are Imuran and Cellcept, and then to a lesser extent, we'll use methotrexate and tacrolimus. And these are all working to suppress the immune system and to just control the disease activity. And as Dr. Mapidi mentioned earlier, we'll often have these going on in the background while we're adding on other therapies like complement inhibitors or FcRn blockers or IVIG even. Typically with these medications, we start with a low dose just to let the body have a chance to accommodate and get used to them. And we'll increase them over time. So I'll typically be checking in with patients every couple of weeks, checking how they're doing on this dose. If everything is good, okay, we're going to increase further. And anticipate that these are used for the longer term. We'll actually taper these off pretty slowly as well. Once we have a patient in remission who's doing well and really wants to be off medications, we're going to go very slow if we're going to stop these. So please do not stop these suddenly. With all of these, we do some lab monitoring. So we send our patients to the lab monthly at first, and then we push that out to every 3 months or so, just for some blood monitoring to make sure we're not causing any side effects. And there's risk theoretically for infection and malignancy because we're working on the immune system, and the role of the immune system is surveillance and protection against these things. So we have to be cautious to keep on top of this, and we're watching for this in our blood monitoring and also in working with patients to assess for symptoms. And for some of these medications, in particular Cellcept, we definitely, and of course methotrexate, we recommend against pregnancy. So if we had a patient who was planning for pregnancy, we would not use these medications, or we would certainly have the patient take contraceptive precautions to avoid pregnancy, just due to risk for fetal harm during pregnancy while taking these medications. So moving on, I'll talk a little bit about some intravenous immunotherapies. Rituximab is typically used for myasthenia gravis, but there are some emerging data to show its efficacy in acetylcholine receptor myasthenia gravis. This one is a large protein molecule. It's a monoclonal antibody that is a targeted therapy. It works on B cells, which are a component of our white blood cells. This drug we have very many years of data and experience with, about 2 decades at this point. It was initially approved for blood cancers, and we've been using it in myasthenia gravis for many years. Very effective and quick to work within 2 to 4 weeks. Patients can either receive 2 infusions on week 0 and 2, or they may receive weekly infusions times 4, and then the cycle is repeated every 6 months. We do give pre-meds because we would anticipate there would be some infusion reactions. We're giving you a large protein molecule, and your body would quite rightly react if we didn't give you some meds like Tylenol, Benadryl, and Solumedrol before the infusion. And we do some baseline lab tests just to check for any infection or risk for infection before we use this med. So if we identify anything, we're going to be addressing that and maybe enlisting some help from some other colleagues in infectious diseases or liver doctors before we would start this therapy. On the next row here, I have IVIG and its related subcutaneous immunoglobulin. It's actually the same drug, but it can be given under the skin for patients who can't tolerate IVIG. IVIG is broadly acting, and in a simplified way of describing it, I'm calling it antibody replacement here. And what it's trying to do is really take the place of the problematic antibodies that the patient's body is producing that are attacking its muscle fibers. So we're trying to just come in with something that's going to occupy the receptors and stop those pathogenic antibodies from being recycled, and to have them exit the system and have these good replacement antibodies in place. The dosing here is variable, it's weight-based, and you could be on anywhere from 1 to 5 infusions monthly, sometimes for several days in a row, every 2 weeks or every 4 weeks, depending on how much is needed for an individual's patient's symptoms. Very well tolerated in general. Patients oftentimes don't need any pre-medications, and sometimes we do give some Tylenol or an antihistamine like Benadryl beforehand. The main side effect that we see with this is headache. So we do recommend the patients keep well hydrated, bring your water bottle or your preferred drink to your appointment as well. And patients do very well on this drug. They do report to us that within a couple of days, they're noticing a lot of extra energy, and sometimes they'll note at the end of the cycle, toward the end of the 2 weeks or 4 weeks or whatever it is, that they can really feel this wearing off and they're ready for their next infusion again. This is a blood product, so very well made from donor blood, but very well scrubbed for viruses and very well cleaned out. But very rarely we can see blood clots, so we do counsel patients to watch for signs of that. And of course, by drinking and hydrating well and keeping mobile if possible, that helps to keep circulation going and to mitigate this side effect. And another extremely rare side effect there is aseptic meningitis, which we use this drug very commonly at our center, and to be honest, this is an extremely rare side effect. And we would counsel patients that if there's any of the meningitis type symptoms, like severe headache or aversion to light, neck pain, things like that, we would want to get them checked out right away. So on that note, for your infusion appointment, just some tips that I'm including here, because these things arise pretty regularly, either whether you're going to an infusion center or having infusions at home. It's important to continue with your meals and your medications as usual. So I've oftentimes seen patients with very low blood sugars or very high blood pressures, things that scare the nurses enough to not give the infusions because of the symptoms going on. So absolutely, you should take your medications as usual on infusion day. You can treat your infusion almost like an airline trip. You're going to be stuck in a finite space for a few hours, so make sure you're dressed comfortably, you're well hydrated, bring some activities to do during the infusion, and just be prepared. You can anticipate that you'll be given some pre-medications just to help calm the immune system so that your body doesn't react to the infusion, and some PRN or as needed medication. So your nurse will always have orders for Tylenol in case you have a headache, or for some medication in case you have nausea or different things, or indeed if there's some kind of an allergic reaction, they have medications to deal with that too. Oftentimes, these drugs will require some post-infusion observation, so you may need to wait in the clinic for an hour or so after your medication, just so they can make sure that there's no side effects or anything that's appearing after the infusion or the injection. Always make sure to schedule your infusion appointments ahead. So typically infusion centers will do this several months ahead. I know it can be very difficult to get on their schedule. Some of these drugs, in particular rituximab and IVIG, take several hours to infuse, so it can be difficult to find an appointment. So make sure that you're planning that out. If it comes to that scheduled appointment, however, and you are unwell or taking antibiotics, please contact your doctor before going to the infusion center. In all likelihood, your nurse is not going to be comfortable with giving you this drug, and it's better for yourself to not waste your time or energy going to an appointment that's just they're not going to be able to follow unless your body is sufficiently well and your immune system is in a good enough condition to accept an infusion. The newest class of drug that we have is the neonatal FC receptor blockers. And the FcRn blockers are definitely being used a lot now. We see a lot of Vyvgart or efgartigimod at our center, and also the newer drug just approved last year is the rosanolixizumab, or Rosie, brand name Restigio. And these drugs work on the body's recycling center, occupying the receptors there and stopping the body from recycling the problematic antibodies that are causing the muscle damage. The dosing here is really interesting. Both are given by cycles. So the Vyvgart is either IV by an intravenous infusion over an hour into your vein, or it can be given by a subcutaneous injection. In either case, it's given weekly for 4 weeks, and then there's 3 weeks off where you have no therapy, and then the cycle can be repeated at 50-day intervals. Restagio similarly is given weekly. This one is given by subcutaneous infusion using an infusion pump similar to the picture here on the right. It goes over about 10 to 15 minutes. That's given weekly times 6, so a little bit of a longer cycle. Again, 3 weeks off, and then that cycle is repeated. So the cycle length there is about 63 days in general. Some of the side effects are listed there, and those are headache, injection site reactions, and some infections. So really quite well tolerated and quite mild side effects with this group of drugs. And then the last drug group that I'll talk about today are the complement inhibitors. These two that I've listed here, Soliris and Ultomiris, are given by intravenous infusion. These are, again, immunosuppressing, and they're targeting a specific protein involved in the immune response called complement. The Soliris is given by IV infusion weekly for 5 weeks, and then every 2 weeks ongoing. The Ultomiris is given weekly every 2 weeks, weekly at week 0 and 2. Twice on week 0 and 2, and then every 8 weeks thereafter. I apologize. The potential side effects here include risk of meningitis infection. Now, the risk is very small. It's only been a few patients in actual practice. However, meningitis is such a serious outcome that we have to take steps to protect patients against that. So we do have to vaccinate all patients at baseline. Other side effects that we would occasionally see are headache and upper respiratory tract infections. Now, at this point, we've been using the eculizumab since 2017, and we have the ravulizumab was approved 2 years ago in 2022, and it's actually the exact same drug. It was just developed with an antibody half-life extension technology, so they were able to add on a little molecule to the antibody to make it last longer in the body. So if you're doing well on eculizumab, as many of our patients have done, and you don't like having to go to your infusion center every 2 weeks, which is completely understandable, you would be probably a good candidate to switch over to ravulizumab. And we've done this with many patients, and they've done quite well with this. It's a good indicator or a good predictor if you're doing well in one that you can switch over to the other, and certainly decrease your need for visits to your infusion center. And the most recent approval, just approved in October 2023, is zilucoplan or Zilbrysq. And this is the same mechanism as the previous two. It's also inhibiting complement. This comes as a pre-filled syringe, which is dispensed directly to patients, and you store it at home in your fridge. Take it out. It's good out of the fridge for, I think, up to 3 months. And you just self-inject under the skin daily. So much nicer than having to go to an infusion center to get your therapy, or having a nurse have to come to you and sitting through the infusions. This really represents a nice new option for self-medication. There's 3 different dosages based on where your weight falls in a particular dosing bracket. That's what you would be prescribed. Again, we have this potential risk for meningitis infection, and some of the other side effects are upper respiratory tract infection, some injection site bruising from the injection, and some pancreatitis, for which we monitor pancreatic enzymes at baseline. And for these drugs, these complement inhibitors, it's really important that we're completing pre-treatment vaccination. And this is mandated by FDA that we protect patients for meningitis. And there's 2 different vaccines that we need to use. There's the meningococcal B and the meningococcal ACWY. So we need to give 2 shots at the start. Then 1 month later, we repeat shot B. And another month later, we have to repeat the ACWY component. So that's the primary vaccination series for meningitis. For patients who have already completed their vaccine series, we can check antibodies and we can just give booster vaccines. But very important, and this is a requirement that has been made even stricter in the past year by FDA, this whole series has to be completed at least 2 weeks before starting therapy with either ravulizumab or eculizumab or zilucoplan. So just keep that in mind about timing. Certainly, we're having to adjust our practices of thinking ahead. If we're considering using these medications for patients, we're starting vaccinations sooner rather than later. We're coordinating with primary care and with local pharmacies to do these vaccines. And then ongoing, we need to monitor patients because these vaccines need to be given booster doses in subsequent years if patients are continuing on these medications for their MG management. So briefly for side effect management, I'll address prednisone because that has a lot of associated side effects. I mentioned earlier for the stomach protection, we'll recommend take that with food. If needed, if you're suffering from any kind of reflux or gastric complaints, we may need to take an acid suppressant as well, something like famotidine or ranitidine or omeprazole. For bone health, we like all patients to take calcium and vitamin D to protect against bone loss while taking prednisone. The typical goal, what's easiest to remember, is about 1,000 milligrams a day of both calcium and vitamin D, and you can buy those as a combination supplement. And then oftentimes patients will need to do a DEXA scan, which is like an X-ray scan of bones to check for bone strength. And if needed, there are other medications that can be given to protect against further bone loss. It's important to be aware that this drug is impacting your blood pressure, your blood glucose, and your cholesterol. So we do recommend that patients follow closely with primary care and keep on top of their checkups and their monitoring so that we can catch side effects before they become an issue. And also we recommend patients to report any issues with mood and sleep because those are known side effects of prednisone, and we need to try to control for that or mitigate those in so far as possible. Some general recommendations also for immunosuppressant drugs is to keep updated on vaccines. So your seasonal flu and COVID-19 vaccines, for example, and then age-appropriate vaccines, which would include pneumonia, shingles, and RSV as applicable. Infection control measures are important. We didn't always recommend masks. Certainly since COVID, that's much more of a consideration if you're going to be in a crowded place and it's maybe wintertime and a lot of bacteria and viruses in the air. But at a minimum, frequent hand washing or trying to avoid people who are actively unwell if possible. Something with an infection, somebody with COVID or with flu, something that's transmissible. It's important to keep up with some blood monitoring labs. If these drugs can potentially cause side effects, it's best that we are monitoring for that and keeping on top of it. And then finally, infusion reactions, just being aware that these can occur with some of these medications and taking the pre-medications when they're offered or recommended. So how about managing exacerbations? So as Dr. Mipiti correctly mentioned earlier, it's really important to track your symptoms or be aware of symptoms and to catch if something is getting worse. Exacerbations have many causes. It can be anything from illness or infection to surgery to stressors like life stressors like work stress or bereavement. Missed medications, meaning ongoing non-adherence to medications, and occasional missed doses is not likely to cause an exacerbation, but somebody who's not getting their medications for whatever reason is more at risk. And then idiopathic, unknown causes sometimes. Flare signs are typically worsening symptoms, weakness, and falls, and we do recommend that you would seek medical attention for this. In rare but serious cases, there can be myasthenia crisis, whereby it affects the breathing muscles and patients require some respiratory support or admission to the ICU. And it is a good idea to think about an emergency card alert. So either something in your wallet or having the emergency profile built out on your smartphone with your contact numbers and something to say you have myasthenia gravis, or maybe even your med list to alert paramedics or providers. And to that end, I'd like to give a shout out to Dr. Mipiti's app, which he's created for smartphone platforms. This one is called Improve MG, and you can get it on your app store. It is compatible with both Google and with iOS platforms. And this is a great way of building your profile here. You can track your health status, log in your symptoms, your medications, and there's also some nice informational articles to give you some information about myasthenia gravis. So what about drugs that you should be avoiding in MG? Now I include this list, which looks a little bit daunting, but it is available on some patient information sites, so I do want to address this. The colors here have no meaning. It's just my slide software that assigned these pretty colors. And please don't get worried by the big names here, but I just wanted to draw attention to a few of these. Namely, the fluoroquinolones would be drugs like Cipro, and the macrolides would be drugs like a Z-Pak. Now, both of these are antibiotics that would be frequently prescribed for upper respiratory tract infections. So what I would want you to take away from this is that if you do present to your doctor for an infection and they say, oh, I'm going to write for an antibiotic, tell them, by the way, did I mention I have MG? There's certain antibiotics that I need to avoid. Make sure they're checking that. Likewise, when you go to the pharmacy, let them know, is this okay to take if I have myasthenia gravis? Because we certainly don't want to give you something that's going to worsen your symptoms. Other medications here are to be avoided to varying degrees. Beta blockers in general, we do not recommend for patients with MG. That said, when patients are very stable and if they need them, they can sometimes use them. Botox would definitely not be recommended for cosmetic purposes, but sometimes medicinally it can be used. And lastly, I'll just call out magnesium. This is totally fine in your diet, or even some oral supplements are okay. It's more so the IV magnesium, which is typically used in labor and delivery and pregnancy to regulate blood pressure. That's where we can have concern for myasthenia exacerbation. So your pharmacist is a great resource. They're your most accessible healthcare profession. Most have PharmD degrees and many have postgraduate studies, so make sure you're using them. And many pharmacists are involved in many aspects of MG management, from comprehensive medication review to counseling, a resource for MG clinicians. They're working in infusion centers, they're working on clinical trials, compounding, and specialty pharmacy. Now I have some other resources listed here. Namely the MDA, who are hosting us today. Thank you for hosting this forum, which is wonderful. The MGFA, the NIH on the Rare Diseases portal, NORD. Various states have their own foundations. So I'm in California, we have the Myasthenia Gravis Foundation of California, and hopefully there's applicable organizations in your local states. And as I mentioned previously, there's some great smartphone apps. MyMG from the MGFA and Improve MG is one that we use at our clinic. And that is it. I'm happy to take some questions.
Thank you so much. I'm going to share my screen so that we can do some questions and answers. All right, perfect. So we did have some questions that were submitted upon registration, but we also have some new questions. So we'll do our best to get through as many of these as we can. Let's see here. We have, is there anything you can recommend to help fight the fatigue?
Oh gosh, that's a great question. The fatigue is a difficult one. It's something we're going to be working on with the immunosuppressants. I can really recommend that you would really take control insofar as you can of diet, making sure that you're eating well, you're getting your fresh fruits and vegetables, you're hydrating, you're getting your exercise as tolerated. The goal is typically 30 minutes most days of the week if possible, but don't stress your body if you're not able for it, or do something that's mild or easy for you to do. And fresh air, just the really common sense, simple things to start with. But I don't have a magic cure for the fatigue. I'm sorry.
Can I add one thing?
Oh, yeah, go ahead.
This is again sort of a practice thing that we do, and partly because we also did a research study and looking at fatigue. There's a significant correlation with sleep, the quality of sleep that you get the night before. There are studies that even a short nap actually changes the myasthenic symptom scores quickly. And sometimes with medications like prednisone can cause weight gain, and one can have sleep apnea from it. And that sort of in a sort of a vicious circle, poorly controlled sleep apnea, a lot of daytime fatigue, weakness, more sleep apnea, so on and so forth. So it's one of those things that I always bring up with my patients when they report daytime fatigue and sleepiness.
Thanks.
Thanks, Dr. Mupidi. Excuse me. Next question is, I was diagnosed with seronegative MG based on clinical symptoms and response to mestinin. Then I had a negative SFEMG and then a borderline SFEMG. My diagnosis was reversed. This happens to others as well. What do you suggest next steps would be?
Being a diagnostic question, Dr. Mipiti, do you want to weigh in on that with the single fiber EMG?
So I feel like we addressed a similar question, Sarah, earlier in the day. Usually, this sometimes when patients have completely well-controlled disease, the physiology might not show up, but that doesn't seem to be the case. In challenges situations like this, I usually recommend a second opinion. It's not that the second doctor is dramatically smarter, but sometimes having a fresh set of eyes without any of the inherent biases the first visit might be insightful. It certainly is possible, and it happens in practice, when we see a patient with myasthenia, and if this disease is really well controlled with long-term therapy, they might become antibody negative. But that usually means that they're not having as many symptoms anymore. But if you're still having a lot of symptoms, it might be reasonable to getting a second opinion here.
Thanks so much. Another question. In the use of azathioprine and methotrexate or any other thioprine drugs for MG, would you also advocate for PGX testing in consideration of the side effects and safety you just mentioned?
That's a great question. So PGX is short form for pharmacogenomic testing. Pharmacogenomics is a field that looks at how your body's DNA or genes determine your reaction to medications. It happens to be a big interest area of mine, but yes, absolutely, we would recommend pharmacogenomic testing at a baseline prior to starting azathioprine. Azathioprine is metabolized by two different enzymes, which their levels can vary depending on the patient's genetics. So for safety, we will typically do a pharmacogenomic test before, we will always do a pharmacogenomic test before we start azathioprine or Imuran. I do know in other locations that providers can check an enzyme activity level if they opt not to do a pharmacogenomic test, but it is a more accurate test and we will definitely recommend that.
Thank you so much. It looks like we have two more questions, so we're going to wrap that up just so we can make sure to respect everyone's time. What is the difference between a sleep CPAP and versus a BiPAP?
It's continuous positive airway pressure versus bi-level. So it's responding to inspiration, expiration. Dr. Mipiti will be probably more familiar with this being a device than me.
Yes.
More focused on
Yeah,
that.
so I think it's a good question. Claire, you're spot on. Continuous pressure versus bi-level pressure. A lot of the times we recommend the bi-level pressure in patients who are requiring ventilatory support or respiratory support at nighttime if it's due to a neuromuscular weakness. With the bi-level pressure, basically what happens is that when you're taking a deep breath in, there's a lot more pressure to get the air in. When you're breathing out, there is not as much pressure against breathing out. With the CPAP, you have a continuous high pressure, whether you're breathing in or not. Oversimplified, CPAP is what is typically used, for sleep apnea, for example, and some of the respiratory illnesses. A bi-level or BiPAP is what's typically used in patients with neuromuscular weakness who are requiring ventilatory support at nighttime.
Thanks so much. We have one more question. So would you recommend a melatonin supplement?
That's a great question. And I know a lot of patients like melatonin as an alternative to traditional sleep aids, which can place patients at risk for dependency. I'm cautious with supplements and immune conditions, and there have been reports of exacerbations of myasthenia gravis in patients taking melatonin. Supplements are also not FDA regulated to the same extent that prescription drugs are, so we're never entirely sure what exactly is in the supplements. So I would exercise caution with the melatonin, to be honest. It's not something I would recommend. I think that that's something that needs to be researched, and you should talk to your provider about before going that route.
All right, thank you so much. I think that's going to wrap up our Q&A session. Thank you so much, Dr. Spahn and Dr. Mupidi. We sincerely appreciate your time and expertise and everything you do for the neuromuscular community.
Thank you so much.
Yeah. So for everyone else, if you don't mind just hanging in there with me for just a little bit longer, I just want to wrap up our presentations here. We hope you will join us tomorrow for day 2 of our learning series on myasthenia gravis. We will be hearing from Dr. Jeffrey Rosenfeld on treatment expectations and from Dr. Leslie Delfiner on considerations for children with MG. Tomorrow's presentations will start again at 4:30 p.m. Eastern Time, which is also 3:30 p.m. Central Time and 1:30 p.m. Pacific Time. If you are new to MDA and have been diagnosed with a neuromuscular disease under MDA's umbrella, or if you are a loved one of someone who is diagnosed, we encourage you to stay engaged with us at MDA. You can do this by visiting mda.org/join and completing a short form. Joining is free and will keep you up to date on the latest research, educational programs, and supports. MDA has ongoing webinars, virtual learning programs, and live events that may be of interest to you. Be sure to check our webpage frequently by scanning the QR tab at the top right of your screen. And MDA would once again like to thank our virtual learning program supporters, Alexion, Argenx, Genentech, and UCB. And we would love to hear your comments about today's webinar. Once you leave the webinar, a web page will automatically pop up with a short survey about today's webinar. Completing the survey will provide us with important insight as we plan for future educational programs. If anyone has questions after this webinar, please feel free to contact MDA's Resource Center at 1-833-ASK-MDA1 or email the Resource Center at resourcecenter@mdausa.org, and they'll be sure to get back to you. Thank you again to our presenters and roundtable participants for their time and expertise. And thank you to everyone who attended day 1 of our MG series. We hope to see you again tomorrow for day 2 of this series. And this concludes today's session. Everyone have a great evening.